Dr. Stephen Klasko is an innovator, a president of a health system, a health plan, a partner at a large venture capital firm, and a DJ, a very good DJ as well. And we were so thankful to have him on the Executive Uninterrupted. Dr. Klasko, thank you for joining us today.
Well, listen, it's great to be on a podcast that starts with perfecting. I'm a long way from there, but glad to be with you.
Yeah, well, we're close enough. And I've always found your story so interesting since we had connected many moons ago, and the innovative entrepreneurial path that you took at Thomas Jefferson. And I'm excited to get more into the story of you today. And we do that on our little show by first going behind the title and all of the accolades and anything like that. So really getting to know Steve today here. And before your executive roles, going back to the younger Steve, what took you into the path of medicine and then business in healthcare, and then becoming a very well-known figure and speaker, and now entertainer as well, an advisor to different government bodies? What was maybe a couple key turning moments that clicked in your brain that said, you know what, I'm going to go into medicine right now and start this path?
So I think the two were luck and breaking rules. I actually started my career as a DJ. I was a midnight to 5 DJ in Philadelphia on WYSP. I was little Stevie Kent. Kent is my middle name. That was my major. And I got fired on my first job after about 2 months because you weren't allowed to bring guests in. And I brought a friend in, and it was a top 40 station. I played the 17-minute, 1-second version of Lucky Man by Emerson, Lake and Palmer because I wanted 17 minutes alone, and I got fired. And I go back to Lehigh University, and they say, well, I said, what am I going to do? Well, you're clearly not going to be a DJ. In a weird way, your minor was chemistry, and you've taken up course, you could take the MedCats. Why would you want to do that? Because again, you're not going to be a DJ and you need a job. Good point. So got a special delivery rejection from my first interview because I debated with the arrogant neurosurgeon. My second interview was at a place where I later became dean, Drexel University College of Medicine. And it was an obstetrician, which I am today. Obstetricians come in a lot from midnight to 5. Turns out they're going through my MedCats and science GPA. We're not impressed. But on the bottom, it said little Stevie Kent, WISP. And they go, wow, you're little Stevie? I almost missed some deliveries listening to your stories. It would be so cool for you to come to our medical school. And 2 weeks later, I'm in Hahnemann. And again, fast forward 20 years, I became the dean of that. I started my career in private practice, and I did what now people hire consultants. Brian, you know this better than anybody. They hire consultants to be patient-centered. I was actually patient-centered. I didn't need consultants back in the 1980s. And we built one of the largest private practices, and I'd still be delivering babies in Allentown, Pennsylvania. If it wasn't for the fact that back then, Brian, 98% of OBGYNs were male, and the number one performed procedure in this country was hysterectomy followed by C-section. Wow. And I happened to listen to an old OBGYN professor, probably my age now that I think about it, but talking about hysterectomy and say, if you see a fibroid, just take out the uterus because a woman doesn't need that after she's had childbearing. Left my private practice job, took an 80% pay cut, and did some of the seminal work on psychologic and sexual effects of hysterectomy. Wow. That then led to my academic career. And then finally, I got very interested, which I think is even more important now, is why do we still accept medical students based on science, GPA, MedCats, and organic chemistry grades, and somehow we're amazed doctors aren't more empathetic, communicative, and creative? Who gives a darn if you can memorize the Krebs cycle when we have ChatGPT Health and call it? So that led to an academic career, became president of a university and CEO of a couple of different academic medical centers, University of South Florida, which interestingly is not in South Florida, it's in Northwest Florida. Says a lot about Florida. And then at Jefferson, I was competing with Penn. And I just said, instead of trying to compete with Penn on their terms, what if we became a 200-year-old academic medical center thinking like a startup company? That led to a relationship with Hemant Asia. We wrote a book called On Healthcare, a Manifesto for Health Assurance, which became General Catalyst's health strategy. What if a Silicon Valley entrepreneur and a CEO of an academic medical center had a baby? What would that look like? And now I'm here.
Wow. And you skipped over a lot of really important things, but nonetheless, I think a jaw-dropping adventure that you've been on, Steve. And I think one of the more interesting parts of your explanation there is where you've started and then where you've gone back to in your love and music. And you actually had a book recently that came out on the focus of music influencing health. We'll get to that a little bit later because I always like a good book promo and to go inside an author's mind for a little bit as well. But
I also got to DJ in Las Vegas at HLTH for the Digital Health Awards.
And I love that. You told me that. And you kept the cocktail hour open and free, I think, too, right?
Yeah, they weren't paying me. They wanted me to stop the free cocktail hour. I said, heck with that. People were dancing till 2.
That's the entrepreneurial guerrilla go-getter, your breaking rules spirit is wonderful. And I think the interesting intersection that most all of your career has been a focus on pediatric and women's health. And you've taken that through a few of your acquisition and partnership opportunities in Jefferson and expanding access to people in greater Philadelphia and Pennsylvania. And then also some things that you've advised in different healthcare settings as well, in government and also in Florida, Northwest Florida, not South Florida. And I think that's always been a really interesting piece to you. So in terms of you going down the obstetrician path, what was the influence there? Is that where you felt comfortable, where you felt called in particular?
It really was. I felt that like my bias is surgical. I'm a pretty good athlete and I wanted to be a surgeon, but I wanted to be part of people's lives. And often choosing a medical career to really be part of people's lives, you're a family practitioner, you're a pediatrician, you're a general internist, and then you're handing things off. OBGYN, at least back then, was one of the few things where you were doing really innovative surgery. I was one of the first microsurgeons doing tubal reversals back then when we were doing gender surgery. It was a very different world, but then you were also literally delivering people's babies and there for the most important part of their life. So it was this unusual combination of being able to use my skills, which I thought I had, and then knowing that I wasn't just going to be taking care of something and then going to the next one.
Wow. I think very, very fascinating. I'll call out a mutual friend of ours, Dr. Jonathan Slotkin. He works on a lot of brains and a lot of trauma, but he does move on to the next brain and the next traumatic episode. And sometimes he gets to see the fruits of his labor and sometimes he doesn't. And I think a very different story with obstetricians, not to tell the two different tales, but he mentioned you just the other day and we shared
we're working together. Yep.
Yeah.
And one of the things when I left Jefferson, it was so weird because I gave my last talk to the medical students as president of the university. And I'm walking out and medical student, actually resident, comes following me. So my mom says, I have to talk to you. I said, look, I'm leaving. It's about tuition or whatever. She said, no, it's not that. You delivered me 31 years ago at Sacred Heart Hospital in Allentown, Pennsylvania. And it's interesting, Brian, because I remembered it. She was like one of the smallest babies I had delivered at the time. It was one of the few Catholic hospitals that had a neonatologist, and I did a lot of high-risk obstetrics back then. Mm-hmm. And she went to a smaller rural hospital and they said, the baby's not viable. And they said, well, look, I'm Catholic. And the mom said, I happen to know that there's a Catholic hospital in Allentown with a perinatologist and neonatologist. This is like 1981. It's, again, very circular things that you remember.
That's unbelievable. I think those stories are probably a lot of stories that you'd shared with medical students coming into programs and putting application and efforts into residency and beyond. So hopefully I would imagine you've inspired a lot of different physicians that are in the world today treating people. And, what I do think is fascinating, Steve, is the approach that you've taken to a lot of this business side too. And we'll get to that in a second, but I want to skip into a bold question I was thinking about as you were explaining that. Today, based on what you've seen as a practitioner, do health plans, integrated delivery networks now, are they really beginning to focus more on women and pediatric health needs because of trend and where we've seen health outcomes be poorly associated? Or is it just the next phase in becoming more whole person care centric? What is it, a trend? Is it really a sticking point that people are committed to? And this is across the board. There's payers in different geographies that see this different ways, but is it something that you think is a real, or is it just a phase?
It's such a great question, Brian, because when you talk to payers or health system CEOs till very recently, what they talked about is orthopedic surgery, spinal surgery, neurosurgery, cardiovascular, because that's where the money is.
Yeah.
And that's also where the expenses are. And that is sick care. And a good part of the book that Heyman and I wrote on healthcare, how do we go from sick care to health assurance? And if you just think about it long term, health assurance starts with moms and babies. So if you're thinking about the next quarter, think about how you can decrease costs for people having spinal surgery or bypasses. And you'll continue to have a broken, fragmented, expensive, and inequitable system. If you're saying, look, our system is not going to fundamentally transform in the next 5 years, let's get over that. And neither the Democrats nor the Republicans have that right. But where we can start to change things is literally looking at the fact that we spend something like 5 times more per obstetric patient than any country in the world. Wow. And there's 3 or 4 countries where health outcomes for mothers have not gotten better. And looking at what happens with a baby, that what you do, those not just physically, but even from a social point of view, you look at what happened with COVID, et cetera, and the decisions we made that might not have been in the best interest of babies. That's forever. So I think we're starting to get some younger folks in the payer world, in the innovator world, in the health system world, saying, look, I'm not going to solve the problem for next year, but I can start to make sure that the next generation has a better healthcare system in America if I take care of moms and babies, even though that's not where the money is.
I like that you were saying that, emphasizing not where the money is there, because a lot of what I'm seeing, and I think where the push was attempted to be from the retail side of healthcare failures the last 5-10 years, is patient-led healthcare, which is a difficult concept for a lot of traditional payers to try to fold into their business model, because that's just not how things work in terms of payment, reimbursement, contracting, negotiated rates, et cetera, for certain services. But it's becoming a real thing.
Yeah. Look, I think one of the Jefferson went from a $1.5 billion one campus university, one hospital entity to, when I left, it was a $10 billion 2-campus university, 18 hospital system with insurance company. That didn't happen by us writing checks. It happened because you said patient-centered. We started to think about the 97% of people that were in Philadelphia that didn't wake up in the morning think they were patient. They were a person that wanted to be able to thrive and have healthcare get in the way. Even when we talk about triple aims or quadruple aims, it's very hospital and physician-centric.
Yes.
Access, quality in the hospital, user experience in the hospital. I think about how does our organization, whether it's General Catalyst Health Assurance or Jefferson, help people at home thrive without healthcare getting in the way? What we called healthcare at any address. And some of that's going to be in the hospital. And one of our first successes, like in health at GC, was Livongo, which got sold for $18 billion. And the genius of that company was a diabetes company that basically said, look, we'll be your invisible friend if you have diabetes. You're not a patient. Klasko, as the CEO of Jefferson, can only say, come to my office, come to my emergency room, come to my urgent care center, come to my hospital. And by the way, we'll partner with Klasko when you need to do that. But we'll be your invisible friend for the other 97% of the time. And I think that's where we need to get to, is those creative partnerships around moms and babies and I think some of it, by the way, is in the entrepreneur side. One of the hears I hear from health system CEOs, we're tired of putting all the Lego pieces together for all the point solutions that you come up with. I advise, or I'm on the board of probably 5 women's health or obstetric companies. And it's hard for a CEO to say, okay, so I can put this and this. Like, why can't you guys all come together and give me one solid way that I can do these 12 diagnoses at home instead of having to go out? And I think we have to reconcile that.
And I think we're getting closer to it with a lot of programs that I think you've had some significant influence over. We'll talk about access in a little bit too, being maybe one of those. And I think it's a beautiful view that you have now from all of the adventures that you've gone through that you just briefed us on to some of those stories that you're telling back in advisory discussions with these firms that you're helping and then also overseeing and investing into. And I think one thing I need to go back to, which was quite interesting in your story at Thomas Jefferson, is how you took them from a 3-ish hospital system to well over 15, and part and through partnership, part and through acquisition. And Einstein was a big deal. I think that set a huge path for success in terms of access for Pennsylvanians and then also Philadelphians in that right. Was that something you felt that was needed not only from the business side, but needed from the people side at that time? How big of a deal was that? Because observers thought it as, wow, that's a big acquisition. But closer to the ground zero, what did that mean for the culture? What did that mean for access in terms of populations?
Well, it was huge for Philadelphia, but in a different way, Brian, it was huge nationally because we had a 2-year fight with the FTC and 2 major insurers that were fighting this tooth and nail because we were going to become the largest health system in Philadelphia. And think about this. Every other safety net hospital in Philadelphia closed. And here they are, the FTC and the insurers fighting me for taking over the last surviving one. I clearly wasn't taking over Einstein North Broad, which literally was 92% government patients to have leverage and commercial insurance. But literally, it was a really tooth and nail fight. And I had said to my board, at the point that we became the largest health system, if all I do is help transform Jefferson, but not transform Philadelphia, then I get a C. And it's like being a great offensive NBA player, but you can't play that, then you're not great. So at the end of the day, we created the Philadelphia Collaborative for Health Equity, had partnered with Einstein. And when Hahnemann literally went bankrupt and got bought by a real estate developer, we knew we had to go after Einstein. And it cost me about $15 million in legal fees. And the fact that we won, and the fact that literally I did an op-ed around that Hahnemann was the canary in the coal mine, and the only question for you, Your Honor, is whether or not the underserved people in North Philadelphia are stuck in that very same coal mine, while the insurers and the FTC were coming with guys in 3-piece suits and talking about the economics is what did it. And I'll give you one anecdote. I have a weird autoimmune disease. I needed a heart bypass in 23. And I went to one of the top 2 academic medical centers. The CEO got me set up to get diagnosed, and I scheduled the surgery. And I called a friend of mine that I had started practice with, the cardiovascular surgeon from Lehigh Valley that I had hired into Einstein's suburban campus, Einstein, Montgomery County. Because I just know, I said, look, I'm really scared about this. I go to my wife, I said, you know what? I think I'm going to get it done at Einstein, Montgomery, because somebody's going to crack my chest open. It'd be nice if somebody like really knows my name. So I got a call from the CEO of this top academic, Steve, like, I heard you cancel the surgery. I understand you getting it done at Thomas Jefferson University or Penn, but Einstein, Montgomery campus? And I said, well, I didn't know what to say. I said, I spent $15 million in legal fees to buy that place. I just wanted to see what I bought. And he said, oh, that makes sense. And it was actually a great experience. I wouldn't recommend it, but it was a great experience.
I like the rationale. Did not know that story. I think myself and many others, obviously, and family included, are very thankful that you're doing well and the procedure was obviously a success. And the rationale behind that, I'm sure, was mixed, but a very interesting story nonetheless. And I think you came out on top, not only from the legal and the business perspective, but the people of Philadelphia and the greater areas in terms of access to high quality care and coordination and service experience, nonetheless, are very thankful for what you put up with for several years. And I think a lot of them thank you in their own ways. So I wanted to thank you with that personally. And I think you've also seen so many different cultures of health. I wanted to look at Thomas Jefferson. I obviously have a nice connection into there as well with my heart, and Florida. So you started on deans of medical education schools in 2 very different geographies. What's something that struck you as interesting that helped you maybe into the business side of your career after, or maybe even during the same time as being a dean for those schools? Any cultural health insights that influenced your business mind there?
Yeah, I think, look, when I got to University of South Florida, it was really almost like a startup medical school. We didn't own a hospital. We partnered with Tampa General. And what was great about that is I was able to look, having spent time in Philadelphia and understanding what was going on in an urban center like that and seeing Tampa that was growing, I was able to look and say, what's wrong? What isn't working? And what's crazy? And what could I do in a place like Tampa and a place called University of South Florida that could be a national model? So we did three things. One was I'm a pilot, and every 2 years I have to get my technical competence assessed. And back when I was dean at USF, I said, every 2 years I have to get my technical competence assessed as a pilot, but as a surgeon, nobody's ever checked my technical competence objectively. So I made a statement, you're a hell of a lot safer flying with me in Tampa than being operated by me in Tampa by objective. We started, at that time, the largest objective simulation assessment of technical and teamwork competence center in Tampa called CAMELS. Actually, the Center for Advanced Medical Learning and Simulation actually built the second one in Jordan. Obviously didn't call it CAMELS. It was called CASTLES, the Center for Advanced Surgical Teamwork Learning and Simulation. So that was an example of clearly a problem, and we can do it in Tampa. I think the second thing we did is we started something called the Villages Health. The Villages is 200,000 seniors that are all, literally everything else is together, but the joke was, where do you go for healthcare? At the Villages, the airport. And we did like a Framingham study. And the two things we found is, as seniors, they have the least amount of loneliness because there were like 2,800 clubs. They also had the highest rate of sexually transmitted diseases. Probably go alcohol, sunshine, and no risk of pregnancy. What could go wrong? Right. But more importantly, we created a patient-owned, primary care-driven health system because we didn't own the hospital. And we could literally say, what if you did this right? And work with the patients and the consumers and not do it based on what does the CMO say. And we brought in 50 primary care docs from around the country. And then the third thing we did is getting back to the new kind of doc. We started a medical school with a health system 1,100 miles away who got it. So you spent your 2 years at the University of South Florida, 2 years at Lehigh Valley Health Network. We erased all the objective criteria, and we chose students based on self-awareness, empathy, communication skills, and cultural competence. And here's the thing, 56 students a year. So you could apply to that select program or to our regular program. We quadrupled diversity. Why? Because the tale of two cities is people spend $150,000 to get little Johnny or little Mary 5 Princeton reviews and a tutor so they can memorize the Krebs cycle and answer the multiple choice test on the MedCats. But when we actually started selecting folks who you would want to see as your doctor or one of your kids would want to see as their pediatrician, and we were colorblind. Wow. And we were also multiple choice blind. And by the way, they had to reach their minimum. So there's no data today, especially with AI and what my iPhone could do, that somebody with a 3.8 size GPA is going to be a better doctor than somebody with a 3.3 size GPA. We still accept most medical students to be a physician scientist at Yale. And by the way, we need physician scientists at Yale, absolutely, but not to be pediatricians in Ocala, Florida.
Absolutely. I love that you took it that way. I've felt the same toward academic rigors and things like that relative to healthcare and obviously relative to other programs, the GRE, the GMAS, ACT, all those different things don't take into frame social, emotional intelligence that's required when you're working with a human to another human about their health. And that's significantly different. And I think everyone has benefited from the programs you had mentioned, and separately in Jordan too, which I did not know, which is fascinating, Castles. But I think CAMEL in particular, a major success. And I did see some really cool literature on the technical testing and because of the reach out to other things that people should be technically tested on, aging in driving, aging in other large automobile and other large equipment. So I think you took something out of industry and you brought it into where it was needed. And a lot of your work has done that. And it leads me to feeling all right. And you've had music in your life for such a long time. We've actually talked to a few good mutual friends on the podcast, Ami Bott, a big musical theater buff, and John White, and many others. And I think for you, you've never let this go. You've never lost the core piece of who Steve Klasko is, aside from all the things you've done. This is not one of your first books, though. This is, I think, one of your most recent, maybe your third or so, among other publications.
Fifth,
your fifth. See, I'm losing track. My goodness, Steve. So I want to talk a little bit about your DJ life and what music means to you and the purpose behind the book too. But what does music mean to you in relative to health right now? Is it a healing mechanism for yourself? Is it something that you're trying to inspire others through simply enjoyment? What does it mean to you?
Look, everybody looks at things differently of what drives them emotionally. As somebody that's delivered 1,500, 1,600 babies and seen fantastic things and horrible things, you need something to ground you. Music was always what grounded me. And what I found is that I get incredibly emotional about music because I had to be in my clinical life, in some respects, non-emotional. I had to be empathetic, but I couldn't break up. So for me, and I run 9 marathons, and literally I would spend probably more time figuring out exactly what song I was going to listen to than exactly what time that I did training for the marathon. But so that was always incredibly important for me. I think most people, not everybody, but if you give it an especially poignant time in your life, you might not remember what year it was. You may not even remember exactly where you were, but you might remember a song you were listening to. At least for me, that's what I identified with. And because my happy place was always DJing for the last almost 50 years. And it just was always fun. Like most of the DJing I do now in Miami is like Afro House and EDM. Obviously in my 20s, I couldn't spell EDM, but I've learned it. And for me, the key is keeping people happy. Yeah. And I'll just give you one quick anecdote. I did a thing on a Miami yacht with Captain Lily.
Oh, man.
And it was mostly 20 some Latino folks. And I was doing that. And by mistake, something came on like, I Can't Help Myself by the Four Tops. And I was like about to, oh God, like where did this come from? And they loved it. And it was like, so I ended up doing like the last half hour. I interviewed Questlove one time from the Roots. And he told this great story where he was asked to do President Obama's Goodbye White House thing. And Questlove's greatest DJ of our time, just brilliant person. But he basically, this is a different kind of thing that I'm doing. And he asked who was going to be there. And he actually like made a playlist. And it's not going well. And it's like 11 o'clock at night. And Barack Obama comes to me and goes, so how do you think it's going? He goes, oh, it just doesn't feel good. And he sees the list. He rips it up. And he goes, I brought you here to be Questlove. We're going to take 15 minutes off. You're in the hood. Be Questlove. And he said the next 3 hours was fantastic. And to me, that's the thing about being a DJ, right? It's getting a feel for the pulse. Like, I'm not a big fan of the same thing. Getting a feel for the pulse of the audience, seeing people happy. What happened in Las Vegas, where it was supposed to end at midnight and people just didn't want to end, is what that's all about.
Wow. I love that because you spoke to a really funny story right there, but it's also chock full of wisdom. Go back to the core of what you're good at. Get in the groove naturally. Sometimes you can prepare, but then reality punches you in the face, and that can set you back into that groove is what I took away from that, and maybe a bunch of other analogies I could come up with. But
yeah, and the book was trying to put those two things together. So the concept is 50 songs that will define the new healthcare. And the first one was ICEA, Courage to Change. And I would argue that's probably our biggest problem. You and I both go to these conferences, often use this quote from Jason Kidd, Brian. He was, for those you don't know, he's a point guard. Yeah. He got traded to the Dallas Mavericks. The Dallas Mavericks are 24-52. And at the press conference, he goes, I'm going to turn this team around 360 degrees. We do a lot of turning things around 360 degrees in healthcare. And I've gone to conferences for the last 4 years talking about the same things: health equity, affordability, access, communication. And courage to change is what we need in leadership. So the second chapter was Keep the Customer Satisfied by Simon and Garfunkel, which is obvious, but it hasn't been very obvious to us. If you remember that song, I've been slandered, I've been libeled, I've heard words I've never heard in the Bible, but I got to keep the customer satisfied. That should be our new mantra. So I was originally going to call it Staying Alive. This is a lawyer story. Staying Alive, how the messaging and music can make healthcare healthier. But some lawyer from the publishing firm decided that the Bee Gees could
just in case.
Now, two of the Bee Gees are dead, and one is pretty gone.
I think Barry's not.
I don't think
Barry's
there's
still here with us. I don't think Barry's.
I think Barry's the one
Barry
who's still
is,
here.
okay.
I think, yeah. But anyhow, so I ended up calling it Feeling All Right because the lawyer didn't know that Feeling All Right was also a song by Joe Cocker and the Beatles. But yeah, it really was trying to take those two things together. Music is emotion. How can we more than incrementally transform healthcare? And what songs could you play in a playlist that would give you the courage to change?
And I think where you were going with that, not only there's a lot more songs that listed in there too, but where you were going with that first song is absolutely applicable to what you just mentioned, Steve, is the courage to change now. And I can't help but go to this very often because it's a point of my personal study and what I hope comes to fruition in changing some, not only outcomes, but the healthcare economic curve to itself and shifting it and making that thing flat. And it's access that's been brought to us by the Innovation Center from CMS, CMMI, Abe Sutton under Oz, a lot of other great contributors, Will Gordon, the CMIO, and I believe a lot of really big influencers that's connected to it, AMA, ACC. And for you, you're a positive person. I overflow with positivity, maybe to my fault. But Steve, I got to ask you, is access for the population we're starting at, cardio, kidney, metabolic, senior population, apps, wearables, is this the promise of the real? We're not on billing codes anymore. We're on outcomes. Is this the real thing that's going to help gradually change outcomes and gradually to change the way things are truly paid for? And that's the big question. Is this the real deal or is it maybe another experiment?
I think it's the real deal if we can overcome the flawed economic model. I think it was Upton Sinclair had this quote, it's hard to get somebody to do something when their salary depends upon them not doing it, right? So look, I'll give you an example. You had asked before, was Jefferson going from 2 hospitals to 18 hospitals or acquiring Philadelphia University? We acquired the number 3 design university because I wanted to look at the design of the human experience, not when they enter a hospital, starting at home. And so I think that the answer becomes, how do you put that all together? And it's hard to do unless you have real strategic alignment. So let me give you one real example. We had a bunch of patients, elderly patients, that would come into our ER 6 or 7 times a year with asthma. They had chronic diseases. And as a hospital CEO, I would say, God, we're losing $10,000 each time a patient comes in. How can I take care of them and lose less money? Okay. Fast forward, as part of our acquisition of Einstein, I get a Medicaid and Medicare Advantage health plan called Health Partners Plan. Now, all of a sudden, they're going into the home, and one of our home health people goes, hey, President Klasko, it looks like most of these people have mold in their homes.
Interesting.
So basically hiring handymen and handywomen to take care of the mold for those 97% of people and keep them out of the ED was great for them. And literally was great for our health system because if you're losing $10,000 a patient, you can't make that up on volume. But it would have been hard for me to do that. So one of the companies that I'm now involved with on board chair is called DocGo. It started as a joint venture with Jefferson Ambulance. We have 12,000 ambulances, but we've now turned that into a health gap company where we partner with major insurers. And this is why I'm optimistic. It's a big part of the access program. We have a lot of government pieces and that kind of thing. We provide the transportation. We might give a patient a vaccine or whatever, but they're trained, and they're mostly like EMTs and MAs, but they're trained to say, hey, this 70-year-old woman that I just helped with her dialysis, all her rugs were loose and she's a hip fracture waiting to happen. Is it okay if I basically get somebody to tamp down those rugs? Obviously, the insurers love that because it gets back to but it's not what traditionally insurers had looked at. It gets back to your first question. How do we decrease spine surgery or whatever? But they're excited now about looking at if we did some of these things. I hate the term social determinants of health. It's a little
very academic
for medical schools. Yeah, they used to talk everything about self-awareness and empathy were the soft subjects. Like, no, dude, biochemistry is the soft subject for a pediatrician. You already got that in undergrad. Like, self-awareness and empathy is not like a soft subject, just like social determinants of health are not. Oh yeah, let's have one day our third year on social determinants of health. Like, even though that's 80% of
Everything you do.
yeah. So Brian, we had the first college population health in Jefferson. It was led by a real living legend, Dave Nash, and Dave would give these very great talks, like when we were together, and I would do my talk is called Swifty Startups in the Singularity. I come back from 2035. I'm the chief digital health officer of President Taylor Swift, because the Swifties have become a political party. And our healthcare motto is make healthcare tailored and make it Swift, neither of which is true in 2025. And we were never, ever going back to that system again. So, but what I remember is that Dave is like so great. He was like giving this talk, and it was like a rural health thing. And he's talking about population health and the burgeoning, and this was many years ago. And then the last 10 minutes was how there's a 21-year difference in life expectancy in Philadelphia and why those things are important based on race and zip code. So this one guy was a chief medical officer of like a 20-bed hospital wearing cowboy hat goes, I know there's a good answer for this, and it's probably a stupid question, but if you're the dean of the only college of population health in the country, why does population health suck so much in Philadelphia? It was actually a great question. And Dave gave a great answer, because it was like, look, I'm the dean of the academic department, but how we move that into, and that's really the issue. We know what's wrong. If I was running things, one of the things that I would do to the academic entities is saying, I'm not giving you, Jefferson or Penn or Temple or Cooper, $1. But what I'll give you is lots of dollars if the 4 or 5 of you get together and solve these problems. Because we all get grants, and so much of the grants are what we can do. And the issue should be, let's take a city like Philadelphia, or in New York now, or Miami, whatever it is, and what are the 4 or 5 things that need to change, and how can you work together, and how can government help you do that? That's what I get optimistic about. When I was the CEO of Jefferson for the last 3 years, I made 50% of my personal incentive solving 5 health equity problems, gap problems in Philadelphia, none of which I had any control over. But it forced me out of the office. We got like a $6 million grant for Southeast Asian folks in South Philadelphia that I didn't even know were among the most underserved populations. We worked with Esperanza, with the Latino population. We worked with the African-American churches during COVID. By doing that, it sent a signal to folks, including the people that work for me, because they wanted that this wasn't just a hobby. It was important.
I like that you put your philosophy and your talk to work. And I think other exemplary leaders in the space have been doing that. Sachin Jain of Scan, and other, I think, formidable leaders. The Chens, I think, started a really big wave, continued off of your philosophy of hiring those that can speak to a culture of the health, not that are scoring maybe the 97th percentile in an NCAT test, but they can speak to a community and treat them to have better health experience and outcomes. And I'm just blown away of learning more of Dr. Steve Klasko, Steve at the core, than I had for all these years. So it's just fascinating what a conversation can take you into. And I am curious of one thing to give us to a close here, Steve. When you were beginning your career in medicine, obstetrician, you went to business, if you could have taken a different path and stuck down the music track or maybe education, would you have done that, or would you have stayed the same path to end up where you are?
I think I probably would have become a podcast author. And I know, seriously, I think what I would have done, I'm getting my master's in literature now at Northwestern, an online program, and mostly experimental fiction, science fiction, and fantasy. And I think that's what I would have done. I think I would have become an author. I mean, just give you one final thing. We're studying now a book by Ursula Le Guin, one of the great science fiction authors, called A Left Hand of Darkness. And it's a society where people can be either gender, and they basically once a month literally pair up, and in whatever gender they are. And one of the great lines is, the king is pregnant, because it turns out that the king got pregnant. And it goes through that whole gender dysphoria. And there's no wars, there's no rape. And this was in 1968, Brian. So the ability to think about problems. My first book was called The Phantom Stethoscope, about a woman medical student that got abducted by aliens an hour before the match. And she comes back 15 years later and they've reimplanted the technical knowledge, but none of the business, legal, ethical, or social knowledge. So they basically taught her what she should have learned in medical school. And those aliens were 3 gendered aliens that got to pick their gender at age 16. So the concept of being able to write and influence people and think about, as Steve Jobs used to say, what's going to be obvious 10 years from now, and start doing it today. I think I would have liked to have done that earlier and been as provocative and piss off as many people as I could, but really maybe have forced some change earlier than I could as somebody that had to work with chief legal officers and nonprofit boards and tamp down a little bit of my provocatoriness.
Interesting. I've seen so many parts of your brain today in the way you think and your approach to life and continued learning. The nuggets of Dr. Steve Klasko are more visible now than before. And I think if anyone can take away a few things from our conversation, it's continued learning, following your true natural path, and not being afraid to do challenging things and standing for what you believe. You've done that throughout different aspects of your career and leisure as well. And you stand true to that. I am so happy to have heard that.
And Brian, the biggest risk in healthcare is not taking risks. If I could, I mean, in our broken, fragmented, expensive, and inequitable system, if you are thinking of being a healthcare leader and say, boy, is this risky? If it's not enough of a change, yes, it's risky.
Wow. And I think that rings true to many people right now making challenging decisions around Medicare Advantage, Medicaid engagement programs, pediatric innovations, and beyond. So I am so thankful to have had you on our show here. Dr. Steve Klasko, thank you so much for being with us here today.
Brian, thanks. It's been a whole lot of fun. Really quickly.
And for more insights, please visit us at outcomesrocket.com.